So thank you for that. I would now like to pass on the mic to Shanna, who's going to talk about the work going on at Interior Health in terms of applying an equity lens to overdose surveillance at Interior Health. Shanna, off to you.
Thanks so much, Sume. Can you hear me?
Absolutely.
Great. Thank you. I just wanted to start by acknowledging that where we're doing this project at Interior Health is located on the ancestral, traditional, and unceded territory of the Silk peoples. But I'm actually delivering the webinar from Vancouver, where I am right now, which is the ancestral, traditional, and unceded territory of the Musqueam, Squamish, and Tsleil-Waututh peoples. So I'm going to give a pretty quick overview of what we're doing at Interior Health as one of the practice sites for the NCCDH Learning Circle project, as Sume had suggested. And our project is looking at how we can apply an equity lens to overdose surveillance at IH. So our team at IH is made up of people from all over the organization, which, as we've learned, is really important to make sure you have cross-portfolio support for the project. I just want to point out that the description I have for Judy Sturm is actually incorrect. It is, she's the Director of Aboriginal Mental Wellness in the Mental Health Substance Use portfolio, so that one's incorrect. And also, I just want to acknowledge that Dr. Bernie Pauly has been acting what we're calling her as our sort of team mentor on our project, because she's been giving us really a lot of one-on-one support as we've been working through this project. So, as I mentioned, the purpose of our project was to support the implementation of a health equity lens in the reporting, monitoring, and surveillance practices related to the overdose crisis. And we were doing this work guided by the Equity Integrated Population Health Status Reporting Action Framework, which was developed in partnership with NCCDH, as well as a number of the other collaborating centers for determinants of health. So what this action framework does is it gives us some direction on sort of the iterative process that we need to go through when we're trying to figure out how do you do something as complicated as applying an equity lens to overdose. And so it identifies who needs to be at the table, including community partners, public health researchers, and then it identifies some sort of broad goals related to communication, collaboration, and applying a lens. And then, as you see on the outside circle, there's a set of iterative steps that you go through as you're doing this. And the way we've actually done this in practice is we've been sort of not in a linear way, because as we know, this work never goes in a linear way. We've been applying these principles in our practice site meetings, where we've been really unpacking the concept of health equity, as well as what does it mean in the context of overdose surveillance, and how can we actually apply this in the real world. So also understanding that Interior Health, just like every other organization, is working within a set of constraints and deliverables and capacity issues. And so really starting to parse out what does this actually look like in practice as opposed to what we think it should look like in an ideal world. And I should also mention that our context at Interior Health is a little bit different. And as Sume pointed out, it's really important to be in an organization that is already committed to equity work. And so I've actually been at Interior Health for the last 2.5 years with a defined portfolio of being an embedded scholar in health equity in the population health portfolio. So there's been really concerted, focused work on systems level work around health equity. And so we're working within a context that already hypothetically supports this work and sees its value. And so that was a really important driver of being able to do this initiative. And the last point I want to make is I know some of you might be wondering, how is data and surveillance related to an organizational capacity initiative? And really our thinking around that was that in a health authority that's driven as one of their goals by evidence and data and responding to that data, it's really important to acknowledge that the way we do overdose, or the way we do surveillance and the data that we collect is not values neutral, and it's not benign. So the information that we collect and the way we present information really dictates the actions that we take and the responses that we take. And so we thought that this was a really foundational piece of work to looking at how do you create surveillance data that actually speaks to equity issues so that we can make the case for equity-oriented responses. And so we're doing this in the framework of overdose surveillance, but it also applies across all health status reporting and data reporting in the organization. So as Bernie already introduced, we're applying the Systems Health Equity Lens, or the SHEL. And I apologize, I realized that the slide I had given to Bernie actually had one of the older versions of the lens, and so this is the most up-to-date version of the lens. And as Bernie pointed out, it's a dual lens, so we're looking at both recognizing health inequities, which by and large is a lot of where the work tends to stop in health systems, and then we're also asking that people look at promoting health equity. So it's dual lenses that we need to do at the same time, hopefully, in order to move health equity work forward. So what does that look like when we're talking about overdose surveillance? So I'm just going to walk you through sort of some of the thinking that was really going on in our practice sites and what's at the sort of core of why we're doing this work. So if we look at overdose and recognizing inequities, what we know is that everybody is being impacted by exposure to an unsafe drug supply and the criminalization of drug use. But what we also know is that people experience the harms of overdose along a social gradient. So people who are impacted by structural inequities, insufficient access to social determinants of health, colonization, and criminalization, they're experiencing a greater proportion of harms than other people. And so it's a really interesting issue to think about equity. Oh no. Is somebody clicking through the slides, Sume?
It looks like we will get it back on track for you. So if you want to
thank you.
Fix that. Sorry about that.
Yeah, no problem. So overdose is a really interesting issue to think about equity because it is a really clear issue where there is sort of a universal or non-discriminatory impact of having an unsafe drug supply, but then you can really start to think about the different ways that people are impacted by the overdose crisis or the unsafe drug supply, depending on where they're located and their multiple identities and sort of where they fall in the continuum related to power and privilege. And so that's the first sort of step we went through, is thinking about where there are inequities. And then the next thing we thought about was, what does it mean to promote equity if you're thinking about overdose? So again, if we think about the harms that impact all people who use substances, so things like criminalization, stigma of drug use, then we can start to think about what we're calling sort of context-specific harms, so things like trauma, income inequality, sexism, poverty, racism. And when we start to think about those things, we need to start to identify a framework that promotes health equity in the sense that it actually protects people from this sort of variety of harms. And so one of the projects that Bernie and I have been working on, which is a equity-oriented scoping review to look at, it's a scoping review to look at equity-oriented frameworks for responding to opioid overdose. And what's really coming out very clearly in that literature is that equity-oriented frameworks have to incorporate harm reduction, cultural safety, and trauma and violence-informed care principles within them to be able to sort of create this umbrella or protection for promoting equity. And again, a lot of this is really responding to the fact that what we do in health systems right now, by and large, around overdose is very biomedical. It's related to sort of the incidence of overdose. So even when we're measuring overdose, it's really bounded to counting the overdose event. There's not very much attention to the context or sort of the life course of how people got there and what happens after that point. And so really trying to think about it from a more holistic point of view of how does this impact our health more broadly and how can we respond as a health system is something we think is really important. So in terms of what are we actually doing, getting down to brass tacks, is we've been doing for the beginning of this project, we've been looking at how do we create what we're calling a draft equity ideal report. And so what we're doing is taking what's currently happening with overdose surveillance, so the reports, for example, that are coming out of the BC CDC, and we're creating our own equity ideal report that's going to incorporate indicators and measures that are informed by that scoping review that I had mentioned, as well as we're hoping to integrate qualitative research findings that are ongoing in the regional area. So we know there's lots of work going on, but that is usually poorly captured and not integrated into the reports that we see. And so we're hoping to reach out to different groups who are doing research in the interior region and seeing if we can draw on some of their data to actually try to contextualize and humanize our data. And then finally, a really important piece of this work is to actually suggest how do you change the surveillance cycle so that you can create the data that we think is important, because it's one thing to say that this is what we want in an equity ideal report, but as we know, if you want organizational change, you actually have to pay attention to the processes that are happening and think about how you can shift those. And one really important piece of that work is thinking about how to include people with lived experience, as well as the community in general, in being able to help shape what surveillance looks like and what comes out of that surveillance so that it's usable and actionable for a variety of different stakeholders. What we're going to do next is we're going to take this equity ideal report and use it in a number of deliberative dialogues. And we're going to do deliberative dialogues just because of capacity issues and timeline. We're going to do it with existing overdose tables in the region. So we're going to talk to the community action teams, and we're talking to, for example, the STBBI network that's in the region. So people who are already working on this issue, and we're going to go to their existing tables and do deliberative dialogues with the goal of extending and revising this draft, as well as really explicitly mapping the regional OD activities, because as we know, in an emergency crisis, there's lots of committees and groups that start going, and then it's a little bit hard to actually track what's going, and then that makes it obviously very hard to collaborate or keep those people involved as stakeholders as you're trying to plan your surveillance. And so, again, addressing some of the structural issues to think about how we can create a more connected network. And then our final goals for this project will be to finalize the equity ideal reporting elements, as well as create an implementation recommendation plan for how you actually put that into practice, not only for overdose, but also just more broadly at interior health in terms of health status reporting. So again, the big question is, how does this help system change? And I really like to use the analogy of watching a pot boil. And so it's kind of hard to see. It's very incremental changes. And so if you think of the metaphor of a pot boiling, I like to think about identifying sort of what are the little bubbles that you need to create to eventually allow them all to come to the top and boil over and see some really big systems change. And so we're trying to monitor sort of these small wins as we go, because if we think of it from a complex system change perspective, we're really thinking about what are all the different levers in an organization that we can start pushing so that we start seeing some sort of communal critical mass movement happening. And so during our project, we've been invited, for example, to present to the medical health officers, different senior leadership teams, overdose surveillance groups, and at all of those tables, we're able to start not only talking about our project, but really expanding people's idea of what is equity, why is it important, why is it something we need to be thinking about. And then we've been seeing some really great incremental changes where from those tables we then are then at different meetings, and we're seeing people on their own bring up these issues and saying, you know, this is something we need to be paying attention to. And so that's how you really start to build this work into a system change initiative where you're seeing champions come from all over the organization, because as we know, it can't just live and breathe with one person or one portfolio. And then the other piece is, as I mentioned, this is happening within a broader portfolio of my work, and so we're actually in the process of moving through organizational systems at Interior Health to look at how we can actually apply the shell across the organization, and we've had some really promising outcomes with that and some great areas that we're going to be focusing on moving forward to apply equity, and hopefully moving towards an organizational sort of vision that includes a defined equity lens, which, as we know, is a really important first step to getting health equity work done, is to actually have a shared understanding of what in the heck does health equity mean. So those are our broad system change goals. And then I'll just leave you with this picture of a member of our team, Katrina Palmondon, is trained in graphical recording, and so she's been actually tracking the work we've been doing as we go along, which has been really nice to see because we get to see sort of the progression of the work and how we've been sort of unpacking these ideas and moving forward. And so I will leave you with that and look forward to any questions.
Great. Thank you so much, Sana. It's really great to hear about the work you're doing at Interior Health. So